Introducing ourselves. Thanks for being here, everyone, in person and virtually. We're really excited to share this information and just get it out there so it's more common knowledge. So my name is Arissa Kyler. I'm one of the pelvic PTs at our Brighton location.
Hi, everyone. I'm Priya. I'm one of the pelvic PTs here in the Greece location.
Hi, everyone. My name is Elizabeth, and I'm one of the pelvic PTs here in the Greece location as well.
And I'm Caitlin Hanley, and I'm a pelvic PT in Victor.
All right, so we're going to get started. Do you want me to press it on here for the slides? Okay. Good. All right, so agenda for tonight, we're going to talk about the physiologic changes in pregnancy, some common conditions, exercise considerations in pregnancy, some common myths surrounding those, diastasis recti, movement during labor, and some things we might want to do at different points during labor, and the overall role of pelvic PT both during pregnancy and the postpartum period. Okay. So some physiologic changes in pregnancy, there's lots of them. So our cardiac output, so that blood that the heart is pumping out, increases 30 to 50% by week 14 alone, so the end of that first trimester. Our oxygen consumption, so how much oxygen we're taking in and needing, increases by 20%. So a lot of times people notice they start getting out of breath really quickly, and they're like, what is happening? All changes early on in pregnancy because we're growing a human. Increased GI transit times. Also in like first trimester, there might be some constipation. So GI changes are very common. The uterus grows 500 to 1,000 times its capacity as baby grows. There is increased vascularity. So I'm talking like blood vessels in the perineum region. So that space between the vagina and the anus. So there's a lot more blood flow there in the perineum and the vagina. The vaginal walls thicken and the connective tissue loosens in prep for labor. There is increased work for a lot of the internal pelvic muscles, but then also the external pelvic muscles too. So we're talking all the hip muscles, the glutes, the core. They're all just working really hard to support the pelvis and baby's growth. And then there's also a thinning of the linea alba. So that linea alba is the connective tissue between the like six-pack ab muscles. So that is thinning and then it stretches to make room for a baby. And we'll talk more about that in the diastasis recti portion. Then stop at any questions or at any point if there are questions either online or in person. Okay. So we also grow a whole new organ in pregnancy, which is pretty wild to think about. So the placenta allows for exchange of fetal and maternal blood flow, nutrients. In the first trimester, its growth is more rapid than that of the fetus too. Okay, so we're just going to go over some benefits of exercise during pregnancy, like a general overview, and then we'll get into some more specifics. So a lot of times people are pregnant, they don't know like what they can and can't do, what's safe, what's not safe, and there's a lot of misinformation on the internet too. So we'll clear some of that up today. So exercise reduces the risk of gestational diabetes, hypertension, and preeclampsia. We'll get more into that. The recommendation is 20 to 30 minutes of strength or aerobic exercise of at least like moderate intensity on most days for people who are pregnant with or without gestational diabetes. So this kind of encompasses all of those who are pregnant, especially those who are already active and then they become pregnant, they can just continue up to their tolerance. There are potential benefits to make baby's heart stronger with exercise as well. And a lot of evidence is starting to show better labor and delivery outcomes. So there's some evidence showing that a stronger core can help with pushing during labor. And then the stronger you are during pregnancy, kind of the faster you recover postpartum as well and can get back to feeling good and doing what you like to do. All right, Priya's going to take over. Any questions so far?
Awesome. Thanks, Arissa. So you guys just heard a lot about, from Marissa, normal physiologic changes that happen during pregnancy, but what happens when we have unwanted changes or some complications during pregnancy? We don't mean to scare you by giving you a lot of information about these complications, but the more you know, the more tools you have to be able to navigate some of these changes if you do happen to experience these things. So we'll talk about the most common complications that people in pregnancy experience. So things like placenta previa, pubic symphysis dysfunction, gestational hypertension, preeclampsia, and gestational diabetes. So let's dive into that. So placenta previa is when the placenta essentially lies on top of the cervix. When we actually look at the statistics, it's very common in early pregnancy. So in about 42% of pregnancies between weeks 11 to 14, people will be diagnosed with placenta previa. But when we look at where they are at week 28, only like less than 1% of women actually still have placenta previa at that point. Some things that we want to think about are just modifying some exercises that we may be participating in. So high impact and moderate intensity exercises may be more recommended to be discontinued. Go ahead. Yep. Question?
I just want to know, for the first few months, I'm not sure. I had a miscarriage.
Mhm.
So are there any of these type of things going on? It happened at the third month. And it was after I had an accident.
Mm.
The doctor told me.
Potentially, if there's a lot of trauma to that area and there was if you did have placenta previa, it's possible that that could be something that happened. There may have been a lot of bleeding or hemorrhaging at that point if the placenta were to maybe detach. So there could be a lot of reasons. This could be one of those things. Hard to know for sure, but it's possible. Yeah.
Would there have been a way to, stop it?
To prevent it. With an accident, I would say it's called an accident because we can't predict that. But I would say, for the most part, when it comes to things that are under our control, like the way that we're moving, the way that we're kind of participating in exercise, for example, you can reduce high impact exercises and just the intensity of your exercises. But really, the key is this last statement right here. We don't recommend bed rest. We recommend people to keep moving, to participate in their daily activities as best as possible. So the more that you keep moving, the more we're keeping blood flow circulation going, the better that actually is. Right? Any more questions or thoughts on that? Yeah. Pubic symphysis dysfunction is another one that arises. It's common in pregnancy. Essentially, it's manifestation of pain right around that pubic bone, which is that front bone right kind of at the front of our pelvis. Usually people will have pain in this area with activities where they're standing on one leg. So if they're putting their clothes on, if they're taking stairs, getting in and out of the car, walking, those kinds of things. Arissa mentioned how there's so much more blood flow circulation to the tissues around the pelvic floor. Those tissues can become pretty sensitive. So we can expect that there's discomfort in that area. The pelvic floor being in a state of tension, which is more in a protective state, those muscles are a little bit more tense, can also cause more pain in that area. Sometimes those muscles can be in that protective tight state because other muscles in the pelvic area are just not strong enough to do the work that we need to do in our day-to-day lives. So in PT, one way that we might manage this kind of condition would be to strengthen those muscles around the hips to take some of the work off of the pelvic floor. So in PT, you may learn ways to strengthen, just to modify day-to-day activities so we're not stressing those muscles in that single leg stance position. Awesome. So there are a lot of words here, and this can look pretty scary. I want to quickly go over hypertension, gestational hypertension, preeclampsia, and gestational diabetes. Essentially, chronic hypertension is when if you are diagnosed with high blood pressure earlier on in pregnancy before 20 weeks. If you're diagnosed with this after 20 weeks or you continue to have high blood pressure, this generally progresses into what we call gestational hypertension. And then if it's not managed well, there can be some other more serious kind of complications in the body. And that's when we call this preeclampsia. And this typically can be a risk for early labor delivery. So we do want to manage hypertension, blood pressure well during pregnancy. And gestational diabetes is really the onset of diabetes somewhere between 24 to 28 weeks of pregnancy. So a lot of complications can arise, but what can we do about this? And what role does exercise play in managing some of these symptoms? When we look at the research, there's a lot of really good evidence to show that exercise actually helps reduce the risk of developing hypertension in the first place. It actually may even reduce the risk of hypertension progressing into preeclampsia. And there's no evidence that if you have hypertension, you should stop exercising. So we really just want to kind of keep moving. When it comes to preeclampsia, like I mentioned, it can be a medical emergency causing immediate delivery, but in people who have preeclampsia, who continue to exercise, they actually end up being pregnant for a longer period of time. So that's great. That's what we want. People who are active prior to pregnancy are also less likely to develop preeclampsia during pregnancy. So that's great. We know the role that exercise can have with managing our blood sugars. So that's no different with someone who's pregnant. So females who are exercising prior to during pregnancy are less likely to develop gestational diabetes. Again, really helpful in managing blood sugar. If you are diagnosed with gestational diabetes, and I would say recommendations are kind of what Arissa talked about, 20, 30 minutes of strength aerobic exercise. So your key takeaways here are just to continue to exercise and how important that can be in managing and preventing all three of these things. Yep.
With my previous pregnancy, I didn't have preeclampsia. They just said I was at risk because I'm advanced maternal age. And then I gave birth, and then I had all the symptoms of preeclampsia for 2 months after birth. And so I guess it wasn't managed then. It just like monitor your heart rate, do your blood pressure, I'm on blood pressure cuff and everything.
Yeah.
So now with this pregnancy, they're like, oh, take baby Tylenol because the last time you had it at the end. But I'm like, I had it after labor. I was fine all throughout pregnancy. I'm like, nothing. Things aren't adding up for me as far as like what to do to prevent it, be it during or after.
Yeah, I would say we can, if we look to our kind of general activity guidelines, if we think about kind of the amount of exercise that you were getting prior to pregnancy, if it's meeting those guidelines and you don't have any other complications and you're able to kind of push into exercising at a moderate or even high intensity without having any complications, generally it can be helpful, but there are a lot of other things that aren't under our control as well, like genetics. So that's part of it too. Any other thoughts on that? Anybody else?
Well, I couldn't do much exercising because I had full belly. I had twins. So just to keep moving from side to side, because I didn't put the back in. From side to side, I was 56 inches around the front.
Yeah, that's a really good point. We're going to talk about how multiple pregnancies can impact what movement looks like during pregnancy. So that's a really good point that you bring up. I would say that maybe it's just kind of going back to your question, the type of exercise that you're doing, the intensity, the total number of minutes, all of those things would probably have to dive into a little bit more carefully just to answer that question a little bit better, if that helps. Yeah. All right, so this is I wanted to go over when do we continue with exercise? When do we want to be cautious? When do we want to completely avoid exercise? So we absolutely completely want to avoid exercise if there's any kind of persistent vaginal bleeding, if there's a ruptured cervix, if someone's pregnant with triplets, if you have multiple sort of babies or like twins you said you had, we probably want to think about maybe just kind of changing or modifying the way that you're exercising a little bit. Severe preeclampsia is an absolute contraindication, sorry, placenta previa and uncontrolled thyroid dysfunction. So if you're noticing any of these things, then we want to pause exercise. Absolutely. But we definitely want to be cautious if there's any recurrent pregnancy loss, history of eating disorder, or any history of preterm birth. Other than that, there's really no issues, no reason to stop moving during pregnancy. All right, that's it. Caitlin's going to take over from here.
Okay, so we are going to talk about some exercise guidelines in pregnancy. So the guideline is pretty much the same as the general population. We're getting 150 minutes total of moderate intensity exercise a week, and then plus another 2-ish days of weight training. There's no correlation with exercise and miscarriage. So there's been for a while, or you may see online, like not to exercise during first trimester because chances of miscarriage tend to be higher during that time. However, the research has found absolutely no correlation between any exercise and pushing your body hard and miscarriage. So you're okay to exercise. Yeah. Yes. And exercising doesn't mean it reduces the risk of miscarriage, unfortunately. Yeah.
The doctor said I had an accident and then I got pregnant after that.
Mm-hmm.
So that would have been he wasn't sure, but he seems to think that was the cause of it.
Yeah. Yeah. It's hard to know.
Problems at all, except for that relaxed day.
Yeah, I'm sorry. Exercise on your back is okay as long as you're not symptomatic. So if you start to feel like lightheaded, dizzy, nauseous, then elevate your head, or just stand up and do something else. There's no adverse effects if you get your heart rate above 150. So this was a general guideline before. We had a lot of general guidelines with no research because it's hard to get ethical clearance to research someone who's pregnant. So they just kind of had this like, well, just don't do it. But now women still did that. And the research is showing, nope, you can go to max heart rate and you're doing good. There's no link to diastasis recti postpartum while exercising during pregnancy. So diastasis recti is the lengthening of your linea alba. We'll talk about it in a minute, but a lot of times I've heard things like your abs are ripping, they're not, or tearing. But it's just making space for baby. When you're pregnant, it happens. Sometimes it comes completely back and sometimes it can be a little bit more lengthened. But exercising, using your core during pregnancy does not make the diastasis worse afterwards. Mamas who lifted heavy during pregnancy had lower rates of mood disorders, gestational hypertension, preeclampsia, and gestational diabetes, which we pretty much just talked about, except the mood disorders. But a lot of these things we know exercise helps with depression, high blood pressure, all of those things. The potential benefits to making the baby's heart stronger is they found that the baby's actually working out with you while you're working out. So that baby's heart rate's working a little bit harder and making the baby's heart stronger as it's making your heart rate stronger. And then we talked about this, some better labor and delivery outcomes as well. So warning signs when you're exercising, when do you need to modify? Like when it might be too much. So if you're dizzy, you may need to decrease the intensity. It may be a day that you just need to stop. Upper quadrant pain. So just having upper abdominal pain that's like being produced while you're exercising, may also want to stop. Difficulty breathing, feeling like woozy. If it's happening when you're lying on your back, just change position. Braxton Hicks isn't something that says you can't exercise if you're having it before, but if you start exercising and all of a sudden you're feeling like, oh, I'm starting to get contractions, it may be dehydration. So just hydrate and decrease intensity. It's not a stop, just if you're running, maybe just start walking or something like that. So bed rest is really now something that we're not recommending pretty much across the board. And you're definitely going to have to talk to your OB if they recommend this, because we are still seeing it. However, bed rest is linked to worse obstetrical outcomes. So it's often still prescribed, but what we're finding tends to be better is more pelvic rest, which is different than bed rest. Bed rest, like you're literally not able to do anything. You're laying in bed, you're becoming deconditioned. Labor and delivery tends to be harder as you're deconditioned. So pelvic rest is having no penetrative sex, doing things that create a lot of load on your pelvic floor, but like hopping on a bicycle and moving your legs is very little to any work on your pelvic floor. So that's like, there's still things we can get moving, get your heart rate up, and not just lying in bed.
My cousin worked as a waitress the whole 8 months. Her kids just popped right out. The doctor told her because she was constantly walking.
Yeah.
She just popped.
Well, good for her. And then, so this is diastasis recti. So, it can look very different between a lot of different women. So pretty much any woman who's pregnant is going to have diastasis recti. And then postpartum, it can look anything like this. But here's the thing. Guys with beer bellies are going to have diastasis recti as well. So it's not something that's just happening in pregnancy. It's something that's happening across the board. Women can have it who have never been pregnant, but the only people who really have been told not to work out, or you could rip your abs if you do this, like certain core exercise or something, is women who've been pregnant or postpartum. So we're really trying to like change this narrative. So this is not your abs are not tearing, like we said. People with diastasis recti may have weaker abdominal muscles, or at least they tend to, or increased pain, but it doesn't lead to greater pelvic floor dysfunction. And some factors that can contribute to diastasis recti would be the type of delivery, time between deliveries. So if you're having 2 babies 14 months apart or something, that's a lot harder on your body, a lot less time for your abdomen to recover in between. If you're having weaker abdominal strength prior to pregnancy, that can contribute. Like if you got good rehab, or if you did no rehab between deliveries, that can change things. Ability to manage pressure. So really ability to engage your core, manage pressure when you're like sitting up out of bed, that kind of stuff. And willingness to scale, like really scale activity to make sure good core activation is present. So if you're doing, let's say you're a CrossFitter and you're really going hard, doing hard crunches, and you're not getting really good core activation, then that could potentially contribute. So just making sure we're modifying if we need to. Okay, so now we're going to start talking about things that we can do for positioning during labor and delivery. So there's pretty much 3 phases that we're going to talk about. And well, I'll say this. So if you're planning on getting an epidural, then most likely you'll be in bed. However, there still are some positional changes that you can do. And then many times early labor, you'll still be at home during some of those first contractions, or this may even be before you have the epidural. So usually during this phase, even if you're having the epidural or not, these can just be ways that you can help manage contractions and pain. So the first thing I want to show you, I'm going to try to do this and hold the mic. So you have your pelvic inlet, which is right here, this circle here in your pelvis, and then your pelvic outlet is between your sacrum and then your sit bones right here. So during the early phase of labor, when your contractions are just starting, really before transition, baby's head is right at the top of the inlet of the pelvis. So we can use movement to open up the inlet. This pelvis does not move very much, but to open up and widen this space. And then when we're pushing, we can end up opening up the outlet like that. So if you can, I'm going to have you take your fingers and sit on them. Try to find your sit bones. And then if you're sitting in your chair, I'm going to have you, so like bring your knees together, and then I'm going to have you bring them both wide and see how your sit bones move, if that makes sense. You should feel them kind of come a little closer together. And then if you bring knees in and feet out, that will widen them up. I know it's hard to kind of do in your chair there. If you want to at home, or if you're at home, on your hands and knees is a little bit easier to feel that. But by bringing your knees wide, or your legs apart and knees wide, that's opening up this inlet portion, making it easier for a baby's head to come through the top of the pelvis here. So these are just some ideas of positions you can do. There's many, many different positions, but in like a deep squat position, side lying if you're in bed, using a peanut ball, it tends to be better, and most hospitals will have a peanut ball available. And then hands and knees, leaning on something, anything like that, and breathing through contractions. We tend to recommend that you're switching positions about every 5 contractions, and working with your birth partner to help you move in, transition from each position. So then when you get to transition, usually transition is when you're feeling like, I can't do this anymore. And like just all the emotions and everything, you start to become very much more internalized. And at this point, the baby's head is pretty much just mid-pelvis. So if baby's head is mid-pelvis here, we just want to be in an asymmetrical position. So getting one leg higher than the other, whether we're using a chair to do so, bringing a leg up on a yoga block. If you're lying in bed, just like, you can envision me lying, just bringing one knee up. Anything where your legs aren't just in the same position. Also, the biggest thing with a lot of these is like doing what your body feels. Like if your body feels like, oh, I really feel like I need to bring my right leg up, then do so. Like don't feel like you need to go by the book or exactly what these say. I would say listen to your body first. And then this is the anatomical things of like what can really be beneficial as far as what your pelvis is doing at that time. So now once we get to the pushing phase, we're trying to open up the outlet. So this is where we bring our knees like in closer together and our feet wider apart. So if you have an epidural, you can do these first 2 positions. You're lying on your back, bringing feet wide and the knees together. And then this again would be better with the peanut. We just didn't have one in the clinic. Lying on your side. I like the side lying position better if you have the epidural, just because your sacrum, if your sacrum is lying flat on the bed, there's not space for it to widen as the baby's head exits. So if you can be side lying, then there's more space for that sacrum to move outward, making more space for baby's head. And then if you don't have an epidural and you're free to move around, quadruped is also a great position. Squatting, many times you have to talk to your OB and be like, hey, I want to give birth in this position. But it's totally okay and acceptable. Yeah.
Before laboring or afterwards?
Before, like while you're laboring, you typically get the epidural, usually before the transition. So, but once you have the epidural, you really don't have any feeling below your waist, or you shouldn't. So you're not allowed to get up and move around because you might fall and you don't really have any stability.
Hospital.
Yeah, so this is while you're all of these positions are while you're laboring. I mean, they're fine for stretches. There's probably better stretches out there than these though. So this one, so like, do you mind just going back to the first? So this one would be like early labor when contractions are still further apart. Then this is more transition when you're feeling more internalized, and that's the asymmetrical. And then these are the pushing positions. Okay. And then I think so.
Cool. All right. So we'll just touch on a few things for the 4th trimester, and then also generally the role of pelvic PT within your pregnancy. I think a lot of the time, women, families, they don't really realize the benefit of pelvic PT until they have gone to their OB and have been given some diagnosis. But the great thing is that in most states, you can begin PT without needing a medical referral. And a lot of the times during pregnancy, you can begin pelvic PT really not even under the direction from your immediate medical doctor or OB-GYN. Because the great thing about beginning pelvic PT within pregnancy is that you can just get a lot of education, similar to what we've reviewed here today, where you get a lot of guidance on exercise, any specific contraindications for you as an individual, and as well as some information as far as preparing for labor and delivery in the postpartum period. And it's also a time where you can build up some of your exercise capacity, your cardiovascular endurance, and then do any pelvic floor specific training that needs to be done that will also be beneficial when it comes to your control and your kind of know-how with active labor and delivery. As far as the 4th trimester is concerned, that's really the time frame that we give after the labor and delivery period. So once you are home with baby, the immediate recommendations from the American Committee of Gynecology is that postpartum care should be ongoing, that it should be obviously initiated hopefully in pregnancy, but also again within just a few weeks of the postpartum period. And the current recommendations are right now within 3 weeks, which is a little bit different than what most people know, because that postpartum check with your OB typically occurs at that 6-week mark. But what we're seeing is kind of an increased time frame as far as when you can get in to begin your pelvic rehab, which is really exciting. To help women get moving again, and also just start to build a community in the postpartum period. This is the 4 trimesters when your exercise routines can be gradually resumed. So think of kind of as you somewhat taper into your labor and delivery, you slowly build and build back out strength training, cardiovascular training, and your other forms of exercise. There are some women who are capable to return to exercise pretty immediate after delivery. This is very or incredibly variable person to person, and can depend on kind of their state of exercise, fitness prior to labor and delivery, and also just the circumstances around them and what kind of kind of support, and as well as other equipment and things they have available to them in the postpartum period immediately. Pelvic floor exercises can also be initiated immediately postpartum. But again, this is where your pelvic PT is so important, because this is where you can be given guidance on kind of the state of your pelvic floor and the symptoms you might be experiencing, and what kind of pelvic floor exercises are the best for you in this point in time. Exercise postpartum, as we kind of talked about earlier, has been helpful and correlated with reduced postpartum depression. And there's no negative effects that have been correlated with stress urinary incontinence or pelvic organ prolapse. So we can kind of break down or think about your postpartum rehab in 3 distinct phases. Phase 1 is really about your recovery and letting a lot of the soft tissue heal within the pelvis, your abdomen, your cardiovascular system, because labor and delivery is so intensive. So it's a nice time to kind of monitor heart rate, blood pressure, be aware of your mental and emotional health. Incorporating gentle breathing, exercises, assessing how your different joints and systems feel. And it's also a time when you can begin scar management and any kind of abdominal care that you might want to. Phase 2 is kind of when you get into that progressive training mode, whether that's aerobic exercise, progressive strengthening exercise, and it's where things can start to become a little bit more sport or activity specific, depending on the individual. And it's also a great time where you can get some nutrition counseling, as well as any specific pelvic health treatments or care that might be indicated. And then phase 3 is really like your return to activity. And again, this is variable as far as how long these phases extend, is very much person to person dependent. But phase 3 is really when you're thinking, okay, I'm getting back to my competitive sport or my recreational sport, or some of those higher level tier exercises and activities that are a higher demand on our bodies, on the pelvic floor, and so on. So some specific considerations in the 4th trimester, just with a lot of the demands of breastfeeding. So we think about the total time that you spend breastfeeding, having your milk come in and how that affects the weight of your upper chest, holding the baby, and what kind of biomechanical demand that places on your upper torso. The 4th trimester is a nice time to work on combating some of those stresses. So working on your mobility, some of your general torso strength and core control, just to meet the demands that your body is now, or that the demands that are now being placed upon your body. And then there's some, again, under the guidance of your PT, you can be prescribed various different mobility exercises if those are indicated for you, in addition to some neck related and upper back related strengthening routines. So are there any questions about 4th trimester or the role of pelvic therapy within pregnancy or postpartum? Yeah, no one needs. No,
Just
yeah.
to clarify, return back to pelvic PT like 3 weeks after
Mm-hmm. Yep.
delivery. And then I guess, will there be an assessment done that first appointment to figure out what we're gonna do moving forward?
Yeah, I'll just keep on.
Like currently we have like a whole plan and stuff like that. So like the whole plan to be created and things of that nature.
Yeah, I'll just repeat the question for the viewers. The question is, can we begin pelvic PT at 3 weeks postpartum? And what may that look like in those first few weeks? And then how does that plan progress? Does that hit it? So yes, around the 3-week mark is when you could return for an in-person PT session. And that would be very much like a first-time evaluation, kind of getting a lay of the land, the status of how you're feeling, symptoms you might be experiencing, orthopedically, how your different joints feel, all of the facets of now being, a new mom and how you're feeling postpartum. And then the exam, as far as anything physical, would likely be an orthopedic screen where we can assess your abdomen, if depending on the kind of delivery you had, a cesarean, we'd assess the scar and how that healing was progressing. And then an internal assessment would be saved for once you had clearance from your OB, your medical provider, because they are going to be the ones to assess for the quality of the vaginal wall healing, your cervix, the uterus, and make sure things are progressing in that timeline they'd like to see. So then after that occurs, then an internal pelvic exam could be performed based on your symptoms.